Okay, perfect. Thank you. Alrighty, so like Laura said, today's presentation is clinical pros for primary care treating depression and anxiety in children and adolescents. This is actually a reprise of this talk just because I know there are a lot of providers that may have not heard this yet. So if there's someone that has been in a previous session of ours with this exact topic, it's the same talk. But of course, if you have any questions, please make sure you put them in the chat or at the end, we can answer any questions. And so for today, our goals and objectives are to recognize the presentation of depressive and anxiety symptoms in children and adolescents, provide examples of how to screen and assess for depression and anxiety in children and adolescents, and then describe the differing treatment options to consider when treating children and adolescents with depression and anxiety. So we're going to start with major depressive disorder. And Siggy Caps is a mnemonic to help remember the clinical presentation of depression. Um, S stands for sleep disturbances, either too much or too little. I stands for decreased interest or interest decreased, or anhedonia, as we call it. The G stands for guilt or worthlessness, so increased guilt or worthlessness. The E stands for energy decreased. The C stands for concentration issues. The A stands for appetite or weight changes, either an increase or decrease in appetite or weight changes. The P stands for psychomotor retardation or agitation, and the S stands for suicidal ideation. Now, in order to be diagnosed with major depressive disorder specifically, one needs to have 5 or more symptoms for 2 weeks of the Siggy Caps symptoms. And one of those symptoms has to be depressed mood and or loss of interest and pleasure. As far as clinical pearls, when it comes to children and adolescents, um, their presentation of depression is different from adults. So with children and adolescents, you may have more mood lability, so changes in their mood up and down. Is what lay people will probably come to you and describe as, my child is bipolar, and it's not true bipolar, but it's a quick changing in mood. They may also show irritability, low frustration tolerance, so getting really, really frustrated over very small things. They may have a lot of somatic complaints, um, so just stomach aches, headaches, things like that. And you may see more social withdrawal instead of feelings of depression. So children and adolescents usually present with much less melancholic symptoms and much less delusional presentation if if they have severe depression than adults would. So when you have an adolescent or adult presenting with irritability, it does not necessarily that mean that this child needs a second generation antipsychotic, because I see that a lot. I see a lot when patients are brought in by parents to be seen by different providers with the chief complaint of irritability. The first thing that I see patients getting prescribed is usually a second generation antipsychotic um, to try to deal with that irritability, whereas first you need to look into and assess for depression and some other mental health issues before before going straight to a second generation antipsychotic. And so we need to make sure to assess for depression and consider treating with antidepressants if that assessment warrants a trial with an antidepressant, because an irritable child may actually be depressed. So when it comes to screening and assessment, we need to make sure that all children and adolescents are screened for depressive symptoms. And if the screen is positive, then we need to thoroughly investigate or evaluate further. We must evaluate for the presence of thoughts of self-harm to self or others, because suicide is now the second leading cause of death among those ages 10 to 34, according to the CDC website. I know the slide says 24, but it's all the way to 34. We also need to assess for the presence of psychosocial stressors, which can precipitate or worsen depressive symptoms. Now, we should consider depression if the symptoms are present most of the time and they interfere with the child's psychosocial functioning and are above and beyond what is expected for the child's age and level of development. So, as far as clinical pearls regarding screening and assessment, one way to screen for um, depression is utilizing tools such as the PHQ-9 um, and uh, and other depression tools like it. They are for screening purposes only and are not diagnostic tools. However, you can utilize the PHQ-9 to follow symptom improvement once you get your initial PHQ-9 score. After that, in subsequent visits, you can continue to give the PHQ-9 to see if there is improvement in symptoms, but it's not to be diagnostic. It's not to say, well, you tested positive on a PHQ-9, that means you are depressed, so we treat for depression. No, you still need to evaluate further because some symptoms of depression are symptoms of other mental illnesses as well. And so we want to make sure that we're not missing anything else that the patient may be actually having by not doing our due diligence to further evaluate after giving a screening tool. And another clinical pearl is do not only screen for depressive symptoms, but also screen and assess for psychosocial stressors that can be present, which can contribute to the depressive symptoms. Because sometimes there are things going on, we our patients don't live in a bubble. So sometimes there are things going on in their lives that will make depression either start or come on, or it will make depressive symptoms worsen. And so we need to make sure to assess for those psychosocial stressors because whatever treatment we give, if the psychosocial stressors are not known or are not addressed in some way, then it may seem that the patient's not getting better with treatment, but it's because there are psychosocial stressors outside of what the patient is experiencing that are making or contributing to the depressive symptoms. And so it can make it more difficult to treat. So we need to make sure to screen for those. Now, treatment regarding meds versus no meds. That's a question that we get a lot, and it really depends on the severity of symptoms. If you have a mild case of depression, um, then you can do psychotherapy only with a patient and do education support and case management for psychosocial stressors if that's needed to help in those cases. So you do not have to do any meds, and then just observe the response to that treatment after about 4 to 6 weeks and see if things are getting better. If things are not getting better in those mild cases and you've tried to address those things, we need to again reevaluate and see what else is going on. Now, in moderate to severe cases, psychotherapy and or medications may be warranted, and it really just depends on what's going on. With moderate cases, um, they may respond to cognitive behavioral therapy or CBT or interpersonal therapy, what we call IPT. Um, by themselves without medications or in combination with medication. But when it comes to severe symptoms of depression, it's always going to be recommended that medication and psychotherapy should be together. So doing a combination treatment for depression versus just therapy by itself, especially when it's severe. Now, as far as clinical pearls for this, though patients may tell you that they are in therapy, be sure to ask about their participation with the therapy. Patients often say that therapy is not working, but when probed, I find that patients have the wrong expectations for therapy. They believe that they can just go to the sessions and that is all that is required from them, and I have to explain to them, they must utilize what they learn in therapy outside of the therapist's office and in real life environments to see significant improvements in their symptoms. So sometimes they'll tell you, well, I'm already in therapy or I've already done therapy in the past. It didn't work. It doesn't work. And when you ask more questions, most of the time they just had unrealistic expectations for what is supposed to happen with therapy. Now, as far as specific medications, um, the um the antidepressants are going to be what we utilize, and first line are going to be the SSRI antidepressants or the selective serotonin reuptake inhibitors, and those include fluoxetine, sertraline, escitalopram, and citalopram. Paroxetine and fluvoxamine are also SSRIs, but I don't typically use either paroxetine or fluvoxamine for depression, especially in children and adolescents. And I'll talk about why, as far as paroxetine in a couple of slides. But fluvoxamine is mostly utilized in cases of severe OCD or obsessive compulsive disorder. So don't typically use that for depression by itself. Now, with the SSRIs as a class, the most common side effects include GI symptoms, sleep changes, increased sweating, headaches, restlessness, change in appetite, and sexual dysfunction. Usually, the side effects are short lived and dose dependent. So, if someone is complaining of those symptoms, I typically tell them, give it a good week or so. If the symptoms are still present and the side effects are still present and pretty severe, then we may have to consider something else after that 7 to 10 days time period. But usually it does improve after that time period. So most of them do not last. Most of the side effects do not last long. Another class of antidepressants includes the serotonin norepinephrine reuptake inhibitors, or the SNRIs, and these are going to be second or third line medications when it comes to treating children and adolescents with depression. These medications include venlafaxine, desvenlafaxine, and duloxetine. The most common side effects for these medications, because of their effects on norepinephrine, include increased blood pressure and tachycardia. So we have to be careful to monitor vital signs when we're prescribing these medications because it can affect blood pressure and tachycardia. Now, there are other antidepressants that aren't necessarily within either of these other classes that are still considered second or third line antidepressants. One of those includes bupropion, which is a norepinephrine dopamine reuptake inhibitor. Now, with bupropion, um, the clinical pro for bupropion is that this one could also be beneficial in children and adolescents with comorbid depression and ADHD. So that's one that, even though it says in this slide that it's second or third line, I might consider using this, either first after trying before trying an SSRI, or maybe even second after trying an SSRI if I have a kid who also has poorly controlled ADHD, and I want to kind of get kill two birds with one stone approach. I will utilize bupropion in those cases. Another antidepressant is mirtazapine, which is a serotonin and adrenergic receptor blocker. Again, this is going to be a second or third line medication. The most common side effects with mirtazapine include increased appetite and weight gain, and then somnolence, and that's due to its effect on the histamine receptors. So we have to be careful with the mirtazapine, especially when it comes to that weight gain and increased appetite. Now, tricyclic antidepressants, or TCAs, are great, great, great antidepressants that work well, but they have a lot of side effects and a lot of medication interactions. And so TCAs are going to be way down the line when it comes to treating depression in children and adolescents. And part besides the fact that they have a pretty severe side effect profile and a lot of medication interactions, the other concern is that if a child or an adolescent with depression becomes impulsively suicidal and overdose, they could end up killing themselves in the with these medications because of the effects on the heart with the tricyclic antidepressants. So I avoid the tricyclics in children and adolescents when at all possible. Again, if I've tried everything else and there's nothing that's working, I may consider a TCA, but I'm going to have a serious talk and conversation with the parents and guardians to make sure the medications get locked up, that the child does not have access to them outside of when they need to take their one pill for the day, so that they don't have that risk of overdosing and killing themselves accidentally because of an impulse in the moment. Now, when it comes to the medications, for the antidepressants, it takes 4 to 6 weeks of consistently taking the medication before one can assess for the change in symptoms. And so this time frame is applicable for each dose change. So say you start a child on fluoxetine 10 milligrams. 4 to 6 weeks from there is when you want to assess how are things going. Are your symptoms getting better? If not, then you may increase the dose to 20 milligrams, and you give the 20 milligrams 4 to 6 weeks, and again reassess at the end of 4 to 6 weeks with each dose change in that way. Now, when we have a patient come back to see us, we always make sure to ask that they are taking their medication every day and consistently, because if they are missing several days, that 4 to 6 range that I'm giving is not going to be appropriate at that time, because they're not even taking their medications consistently. So we have to make sure we assess for that and ask them how many times are they missing their medication. Now, I expect patients to miss their medication, at least 1 or 2 times a week. It's not ideal, but being realistic, that will happen, especially if some parents are allowing the children to take over their medicines on their own, which I don't recommend, but some parents do allow that, especially in older kids. And so there can be times when there's going to be some doses getting missed, but hopefully they are consistently taking it majority of the time for 4 to 6 weeks, so that we can assess if it's working or not. Now, regarding clinical pearls with the medications, like I started off, in general, we start with the SSRI class of antidepressants when treating children and adolescents, because they have a more tolerable side effect profile. When starting with the antidepressants in children and adolescents, utilize the start low and go slow mantra. So start with a low dose first to decrease the risk of side effects, and then slowly increase over time. Again, increasing every 4 to 6 weeks. When patients say that they do not have any improvement in their depressive symptoms after 4 to 6 weeks, like I talked about in the last slide, be sure to ask if they are taking their medication every day. Depending on the half life of the antidepressant that they are taking, missing just one dose could disrupt the steady state of that medication. Now, regarding which SSRIs to prescribe, fluoxetine has the longest half life of the SSRI antidepressants, and paroxetine has the shortest half-life of antidepressants. So because of this, I generally stay away from paroxetine with children and adolescents, because the withdrawal effects from just missing one dose of paroxetine are very, very uncomfortable. However, with fluoxetine, a patient can miss a dose and it would not change the steady state of the medication in the body, because of how long fluoxetine stays in and has its half life. So I like using fluoxetine in children and adolescents when possible, because it is highly likely that they will miss a dose at some point, especially adolescents. Now, after you say a patient's been treated with an antidepressant for one dose, is stable for a while, when do we consider how long should someone stay on an antidepressant? And what I typically tell families is that you should consider treatment. You should continue treatment with an antidepressant for at least 6 to 12 months after remission of symptoms, and maybe over a year if the patient had severe depression prior to the medication. But at that point, you can start to taper slowly the antidepressant, decreasing the dose, and monitor for recurrence of symptoms with each dose decrease. And then if you're able to decrease to completely getting the patient off the medication, then that's wonderful. That's what we want. Now, when it comes to the antidepressants and the black box warning, there is a black box warning of antidepressants. All the SSRIs have this black box warning. Sorry for getting tongue tied, for suicidal thinking and behavior, but not for suicide attempts up through age 24. Okay, so this black box warning is not that the patients with antidepressants completed or attempted suicide. It's just that they had increased suicidal thinking and behavior, but they did not increase suicide attempts. Now, let's talk about the suicidal ideation statistics, just so you can have an idea of what that difference is. So suicidal ideation across all patients taking antidepressants is 1% in youth treated with an antidepressant, compared to 0.2% for youth treated with placebo. And so in order to cause harm or increase the risk of suicidal ideation, the number you would need to treat to cause that harm, the number of patients you would need to treat to cause that harm would be 143 patients to cause one harm of someone having increased suicidal ideation. Whereas the number needed to treat, or the number needed to improve depressive symptoms, is 3 patients out of all your patients that you're treating for depression. So because of that, there is an low risk. There's a low risk for increased suicidality, but despite this low risk, it's recommended to monitor closely for suicidal ideation, which is recommended by the FDA, especially in the first months of treatment and following dose adjustments. Now, regarding pharmacogenetic testing, which I know a lot of people have heard about, this randomized controlled trial was published in the Journal of the American Academy of Child and Adolescent Psychiatry in June of 2021. And this study did not find any differences between the treatment as usual arm versus the pharmacogenetic testing arm regarding symptom improvement, side effect burden, or satisfaction. So the pharmacogenetic guided treatment did not show improvement outcomes compared to treatment as usual in children and adolescents, in adolescents with depression. So the clinical prior here is that at this time, there is no clear role for pharmacogenetic testing in medication selection. Thus, there is no need to get these results to help guide you with which medications to try in a patient. Just follow the process described in this talk, which includes starting with an SSRI, antidepressant, and then going from there, instead of utilizing the pharmacogenetic testing. Now we're going to switch gears and talk about anxiety disorders in children and adolescents. I show this slide because anxiety can present itself in many ways, and anxiety is very, very common in children. It's actually more common than depression in children, and it gets missed a lot because anxiety can present itself in different ways. And so, some of the ways in this this picture shows, the desire to control people and events, difficulty getting to sleep, feeling agitated or angry. So again, when I was talking about irritability being a common symptom in children and adolescents with depression, feeling agitated or angry is also a common presentation of anxiety in children and adolescents. Defiance or other challenging behaviors can be present. Having high expectations of self, including schoolwork and sports. Avoiding activities or events, including school, so school avoidance, having somatic symptoms such as stomach aches and headaches, struggling to pay attention and focus. That's common, that's important too, because that's a symptom of depression. Decreased focus and attention is a symptom of depression. It's a symptom of anxiety. It's a symptom of ADHD. It's a symptom of a lot of different mental illnesses. And so when we have someone that comes in with the chief complaint of struggling to focus and pay attention, we have to not forget that depression, anxiety, ADHD, all of those can cause issues with focus and attention. Someone with anxiety, a child with anxiety can have intolerance or of uncertainty. They may have crying and difficulty managing their emotions. They can have issues with over planning for situations and events, and they can have feelings of being worried about situations or events. So, when it comes to describing anxiety, um, children and adolescents may present with fear or worry that they do not recognize as irrational. They may have common complaints of somatic, they may complain of somatic symptoms such as headaches, stomach aches. They may have crying, irritability, anger outbursts, which can be misunderstood as defiance when the child is actually trying to express their feelings of anxiety or avoid a stimulus which is causing their anxiety. So, a clinical pearl regarding anxiety is that fear and worry is normal and common throughout the different stages of childhood. But what we must do is distinguish developmentally normal anxiety from anxiety which is impairing the child's functioning. And we also need to evaluate the context in which the anxiety symptoms arise so that we can adequately and accurately diagnose the condition. So, clinical presentation of separation anxiety. Separation anxiety is a significant fear and distress when separating from home or from parent or caregivers. The child may worry about the parent's safety and health when separated. They may have trouble sleeping alone. They may show signs of school refusal, and they may complain of somatic complaints. These symptoms The symptoms of separation anxiety are developmentally inappropriate. So there are times when we should see separation anxiety in children, typically around 9 months old is when we should normally see it in an infant, but that after that time period, after about 9 to 12 months, this should not be something that is still happening in a child. If it is after that age range, then we're dealing with separation anxiety. Now, specific phobia is a fear of a particular object or situation that is avoided or endured with extreme distress or impairment, and is related to that specific stimulus. And a person may have one or more specific phobias. So when we think about specific phobias, we can think about a common specific phobia that lay people even talk about, which is arachnophobia. So the fear of spiders. Someone can have fear of heights, fear of elevators, fear of small spaces. Those are particular fears where you may not see, or the patient may not experience symptoms of anxiety until they encounter the specific stimulus which they have feared. Generalized anxiety disorder is the chronic excessive worry in different areas, and the person or patient has trouble controlling that worry. The worry is present most of the time, and the worry is not limited to a specific object or situation. So, generalized anxiety disorder is what I refer to as my patients that are what I call worry wards. So they worry about any and everything all the time, no matter what. They're coming up with all these different worries and scenarios in their head. They're overthinking. They cannot control their thinking. They just worry about everything. When I ask someone what do they worry about, they will literally say, especially adolescents, I worry about everything. That's how they answer that question, and usually that's a clue that we may be dealing with generalized anxiety disorder in a patient. Then there is social phobia, which is anxiety in one or more social settings or during performance situations. This includes a fear of social scrutiny and doing something embarrassing, and they may have difficulty answering questions in class. They may have trouble reading out loud in class. They may have trouble initiating conversations with others, and they may have trouble attending social situations. Selective mutism falls under the anxiety disorder category in the DSM. And so selective mutism is a consistent failure to speak in specific social situations where speaking is expected despite speaking in other situations such as at home. So with selective mutism, you will usually get a um, clinical presentation of a kid who talks to family at home, but if they go to a restaurant, they cannot order their own food. Or if they go in a store, they cannot speak to someone and get assistance. Or if they go to school, they don't talk in school whatsoever. They don't say anything in school, but then when they come home, they talk to everybody in the family in sometimes incessantly. So that's when you know you have selective mutism situation. Agoraphobia is the excessive or worry about being in a situation in which the individual may not be able to escape. And agoraphobia can occur with or without panic disorder. So you can have it without panic disorder or with panic disorder. But basically, it's a fear of being in some situation where they're not going to be able to get away and get to safety. Now, panic disorder is the recurrent, unexpected episodes of intense fear. The patient will have the fear of recurrent panic attacks, and they may develop an avoidance of settings where panic attacks previously happened. And then the patient must have four or more of the following symptoms during a panic attack in order to be diagnosed with panic disorder. And so that includes palpitations, sweating, trembling or shaking, difficulty breathing or shortness of breath, feeling of choking, chest pain or discomfort, nausea or abdominal distress, dizziness or lightheadedness, chills or heat sensations, numbness or tingling, feelings of unreality, derealization, or feeling detached from oneself, depersonalization, fear of losing control, and fear of dying. So, one of four or more of those symptoms must occur during the panic attacks, which are recurrent and intense and unexpected to occur. Now, regarding the screening and assessment of anxiety disorders, screening is recommended during the first mental health visit because there is a high prevalence of anxiety disorders among children and adolescents. Early identification can facilitate early interventions. Now, tools that you can utilize for the screening of anxiety in children and adolescents include the SCARED screening tool, which SCARED stands for Screen for Child Anxiety Related Emotional Disorders, the GAD-7, which is the Generalized Anxiety Disorder Screen, um, the SCAS, which is Spence's Children's Anxiety Scale, and or the Preschool Anxiety Scale, which is a parent version. All of these are available online for free, and the Scared and the GAD-7, I believe, is included in the welcome packet of those providers who are enrolled in CPAN. Um, Again, these tools are only for screening and are not diagnostic. So you will need to have conduct a thorough evaluation to further assess the symptoms. A diagnostic evaluation will identify the following. They will identify the symptoms, the symptom combination, the symptom frequency, severity, onset, and duration, the degree of associated distress and functional impairment, developmental deviations, and physical signs. Now, there are several psychiatric conditions that may have symptoms like anxiety that you must rule out: ADHD, autism spectrum disorders, depression, and learning disabilities. And now, so you must you must attempt to rule those out, but they also can be co-occurring with anxiety. So just making sure that you're not missing anything when it comes to treatment options, when it comes to how to help the patient get better. We want to make sure we're just not missing anything. Again, these can be co-occurring or they can be individual diagnoses, but we need to make sure we evaluate further to determine which is the case. Now, when it comes to treatment, meds versus no meds for anxiety, again, it's going to depend on the severity of the symptoms. So, with mild cases, just like with depression, we can start with psychotherapy alone. With moderate to severe cases, we can utilize psychotherapy with or without medications. Now, there are different reasons for combining medications with therapy, um, which include we need an acute reduction in moderately to severe cases to help with therapy. We need to treat medications along with therapy to because there's a co-occurring disorder that requires medication, and we need to make sure we're adequately treating that because that's affecting the therapy. And then in cases where there's a partial response to psychotherapy alone, so like say that there's a mild case and it's some response to psychotherapy, but it's just not a full response we would expect, then we're going to utilize medication in those cases as well. Now, the American Academy of Child and Adolescent Psychiatry recommends combination therapy, CBT, and an SSRI that could be offered preferentially over SSRI or CBT alone in patients ages 6 to 18 with social anxiety, generalized anxiety, separation anxiety, specific phobia, or panic disorder. And our clinical pro here is that we need to monitor for improvement in functional impairment and not just anxiety symptom reduction with treatment. And the reason for that is because anxiety is never going to go away 100%. So if you ask a patient if they're still anxious, there are going to be moments when they're going to be anxious because like I talked about when we first started talking about anxiety, anxiety is common and is appropriate in some cases, just not it just should not be impairing functioning. So if we see an improvement in functional impairment, their functioning is no longer impaired, but they still have anxiety, that is okay. That tells us that the treatment is working because they should still have some anxiety. We're never going to take it away completely. So we need to make sure that when we give give treatment, we explain that to our patients, but that's also the expectation that we as providers have ourselves, because we are not going to make anxiety go away 100%. Now, as far as treatment for anxiety, cognitive behavioral therapy, or CBT, shows the most evidence for treatment of anxiety disorders. And the components of cognitive behavioral therapy include psychoeducation about the illness, and cognitive behavioral therapy with parent and child. Um, CBT includes somatic symptom management skills training, cognitive restructuring, exposure methods, relapse prevention plans. And then with CBT, the therapist may have to make some kind of modifications for specific diagnoses. But again, ACAP recommends that CBT be offered to patients ages 6 to 18 with social anxiety, generalized anxiety, separation anxiety, specific phobia, or panic disorder, because CBT is so effective in those cases. Now, other forms of therapy may be utilized, but they're not as extensively studied in anxious children and adolescents. Now, when it comes to medications, clinical pearls for medications, we're going to consider medications when anxiety disorder symptoms are moderate or severe, where the impairment makes participation in therapy difficult, or when there is a partial response to therapy. Just like with depression, the SSRI antidepressants are going to be our first medication of choice in treating children and adolescents with anxiety disorders. SSRIs are the medication of choice for anxiety disorders in children, and ACAP recommends offering SSRIs to patients ages 6 to 18 with social anxiety, generalized anxiety, separation anxiety, or panic disorder. Again, we're going to go with the mantra of start low and go slow with all the antidepressants. Start with a low dose first to decrease the risk of side effects and increase slowly over time. Again, when patients say that they have not had any improvement in their anxiety after 4 to 6 weeks of taking the medication, we're going to be sure to ask if they're taking their medication every day. Because again, depending on the half life of the antidepressant that they are taking, missing just one dose could disrupt the steady state of the medicine. We can consider a medication-free trial when a patient has remained symptom-free. And when we say symptom-free, meaning symptom-free and no functional impairment. So they may still have anxiety in appropriate situations, but not impairing unrational uh, anxiety symptoms for at least 1 year, and then just slowly taper off and continuously monitor for recurrence of symptoms. Other antidepressants may be tried in patients who have failed treatment with SSRIs, but there is minimal evidence to discuss their efficacy in children and adolescents. Benzodiazepines have not shown efficacy in controlled trials for anxiety disorders in children and adolescents. They can be cautiously used in the short term to achieve rapid reduction in anxiety symptoms while waiting for an antidepressant to take effect, but they should not be used for the long term in children and adolescents. And me personally, I typically stay away from the benzodiazepines in children and adolescents, and try to use other medicines unless it's just absolutely no way that I can get away from it. I'll try just about everything prior to um, benzodiazepines. Buspirone is a well tolerated medication and it can be used for generalized anxiety, but there are no controlled trials of buspirone in children and adolescents. You can safely use 5 to 30 milligrams BID in adolescents, and then 5 to 7.5 milligrams BID in children. The most common side effects of buspirone include headaches, lightheadedness, and dyspepsia. But I typically use buspirone quite a bit when I'm treating a kid who has anxiety and an antidepressant alone is not controlling it. I will I will use the buspirone as an add-on, and sometimes even by itself if a kid is not able to tolerate um, an SSRI or an antidepressant of any sort without a lot of symptoms. I will utilize buspirone by itself sometimes. So these are the resources for today's presentation, and now it's time for questions.
Thanks, Dr. Johnson. I sure appreciate it. So we have about 15 minutes for questions. I don't have any in the chat, so what I'd like to do is go ahead and open up the floor for questions for anybody who might be interested. And you can just go ahead and unmute yourself.
Can I ask a question about how you approach parents and talking to them about anxiety when they do come in describing the chief complaint, impulsivity and inattention, and wants medication for ADHD?
So in those cases, I just explained to parents, while impulsivity, inattention are common symptoms of ADHD, and after doing my evaluation with your child, it's my professional opinion, I do not believe your child has ADHD, and that is not the cause of these symptoms, but that your child actually has, anxiety, which is causing these symptoms in your child. And so I explain it to them like that. And, sometimes they may get mad and try to say, no, it's ADHD or whatever. And I say, well, that this is my professional opinion. I'm sorry, your child does not have ADHD. That's not the cause of this. I'll give specific examples out as to how how I reached my professional opinion, and then just go from there. Most of the time that usually works, but sometimes I do know, a lot of parents specifically try to push for the ADHD diagnosis, um, especially like, if they have a history themselves or something like that. Um, so I will utilize, I will, just put it to them in that way. And if they don't like it, then I tell them they can find a different provider, but this is my professional opinion. Did that answer your question?
Yes, thank you. I just wanted to kind of get ears on how other people approach it. I appreciate it.
No problem. Thank you for asking.
Dr. Johnson, there is a question in the chat from Dr. Turner. Is buspirone also approved down to age 6?
So buspirone is not FDA approved for children to utilize. So everything that I've talked about, though utilizing buspirone, is not, it's not approved for that age range. Can you use it? Have I used it? Yes, I have, down to that age. If I've tried antidepressants and other treatment routes, and it's nothing else is working, have I done it before? Yes. So it would be off label. It's not FDA approved to that age though.
And
A
then
lot of
there's
what
another.
and a lot of what we do in child psychiatry is off label from um the FDA, because we don't
There are a
have the
couple
clinical.
questions in the chat. Are you able to see the chat, Dr. Johnson? Now, and I
Yes,
won't
I have it
interrupt
pulled up.
you.
I have it pulled
Okay,
up.
perfect. Okay.
Um, so yeah, the question regarding, do you ever use or refer for computer testing for ADHD if a parent does not agree? If a parent does not agree, I don't. I will refer for neuropsych testing for ADHD if a parent does not agree, um, because that is usually helpful to get a full look into exactly what's going on, and if there is true ADHD. Neuropsych testing pulls out that information very well. I don't recommend like anything that they can find themselves, because I know some people will say, "Well, I took this online test that said I have ADHD," and the uh, the questions are kind of leading questions, so it can be real easy for someone to test positive for ADHD on those like self question one. So if someone is not agreeing with me when I say they do not have a diagnosis of ADHD, then I can refer to um, neuropsych tests, or I can refer for neuropsych testing, or like I said, I can tell them they can see a different provider if they would like to get another opinion. Um, and you're saying you didn't clarify your QB testing. Valerie, can you tell me exactly what you mean and speak up for me, just because I'm not sure what you're talking about and I want to fully answer your question.
I meant not just online testing or computer testing, but specifically QB testing, something that's been validated. So that's what I meant.
Oh, I don't know what QB testing is. I don't use that to diagnose with ADHD. To
Okay.
use to diagnose ADHD, I don't even know what that is. So that's something I'm gonna have to look up because I don't even know what that is.
Okay. All right. Thank you.
No problem. Does buspirone help with difficulty falling asleep for anxious individuals? So it depends on the reason why they're having difficulty falling asleep. Typically, if they have more like ruminating thoughts as their reason for difficulty falling asleep, and so sometimes it can help in those cases and sometimes it's not helpful, so it's really a case by case basis. um I've had some patients that swear by buspirone. It cures all of their anxiety, everything is gone, they can sleep well, all of those things. And then I have some people where they feel like buspirone does nothing for them, so it's literally a case by case basis. But in those patients whose difficulty falling asleep is related to their ruminating thoughts related to, like generalized anxiety, and if those ruminating thoughts have been helped with the buspirone, then yes, their difficulty falling asleep improves, if that makes sense. Dr. Edom, does that make sense what I'm saying?
Yes, yes, it does. Thank you.
No problem. And Dr. Turner, you asked, will you usually try other categories such as an SNRI before using buspirone? So typically what I do is, if I tried an SSRI and say that they're getting benefit from the SSRI, but we're max dose, no further improvement is happening, but they have had some improvement, I will add buspirone in that situation. Um, if it's someone who has tried an SSRI, they didn't tolerate the SSRI at all, I will probably try an SNRI and see if that works better for them. Or I may even try mirtazapine, um, see if that works better for them. And then if not, then I will go and try buspirone. So again, like you said, it's case by case basis, but that's kind of in general as I can make it right now in this situation. That's kind of how I typically get to buspirone. Does that
Okay,
answer
thank
your
you.
question? Okay.
Thank you.
You're welcome. Um, what other comorbid do you screen for in the setting of concerns for depression? Um, Sleep apnea, sleep disturbances, yes. Disordered eating disorders, yes. Abuse, yes. Literally all of that. I will I will screen for definitely screening for abuse. I screen for abuse every appointment, because of the amount of abuse that unfortunately happens to children and adolescents. I screen for abuse in all settings. But when it comes to depression, yes, because sleep issues could be caused by sleep apnea, the poor appetite, or decreased weight. Gotta make sure you rule out eating disorders and make sure that that's not playing a role. The decreased concentration, again, you need to screen for ADHD and make sure that that's not a factor for decreased concentration. You got to screen for anxiety to make sure that's not the reason for the decreased concentration. And even increased guilt and worthlessness. Um, you should screen out like ADHD. There's a lot of kids who have undiagnosed ADHD, and you would think that they were more depressed kids because they have a lot of guilt or worthlessness because, you know, they're constantly getting in trouble all the time. So they don't have a lot of self-confidence, and they will feel, you know, worthless and down. And it's not that they're depressed because of depression. It's they're depressed because they have not been diagnosed with and have not had their ADHD treated. So all of that is is things that you should look out for, to make sure that those are not comorbid in the situation with depression. Dr. Edom, your question is, how do you treat anxiety when OCD is a major component? So OCD treatment is with antidepressants along with specific therapy. And so what the only thing that changes treating anxiety with OCD playing a role is that you may have to go to higher doses of the antidepressant in order to target the OCD, because OCD is typically difficult to treat for the most part, and takes higher doses of the antidepressants in order to adequately treat the OCD. So nothing really changes except for they will need to be in therapy for their OCD, and that you might have to go to higher doses of your SSRI when you're treating anxiety in the context of OCD. You're welcome, Dr. Edom. Any other questions?
Well, we've got some excellent questions today, and this is, this is great learning from everybody. I appreciate those of you that are on the phone that are asking these questions. This helps us to know, as we are building continuing education through the balance of the year, what other topics, or maybe those topics that need to be expanded upon, what we can provide you. We have about 5 minutes left. If there are any topics that you would like us to touch on during the balance of this year, we would really appreciate you adding that into the chat, and any other questions you might have here for Dr. Johnson. Those will be appreciated as well. You'll see on your screen the QR code for today to obtain your continuing education. We do have the next continuing education session, which will actually be a pediatric grand rounds. That is scheduled for the 19th of May, Thursday, May 19th from 12 to 1. And we would appreciate any opportunity to continue to serve you. So we hope you join us for our UT Tyler Health Science Center, CPAN, pediatric grand rounds. That will be actually a session on autism spectrum disorder, and it'll be a panel of experts from our community that are on that panel. So we hope you join us. If you're not part of CPAN yet, we encourage you to join us here at Texas CPAN. If you are a Texas PCP serving patients under age 23, we would love to be able to provide you with support with child and adolescent mental health services through consultation, assistance with referrals and resources, and of course, more continuing education. We would like to thank you for today and joining us, and have yourself a great day.